So it's 10 seconds to go. And it's 3, 2, 1. Ma'am, we are live to the attendees platform. Over to you, Dr. Charmi, ma'am.
Very good evening, one and all. Myself, Dr. Charmi Prajapati from Medical Affairs Team of McLeod's Pharmaceutical, welcome you all to today's webinar. The topic for today is ARNI in heart failure management from bench to bedside. And to dig deeper into the topic, we have with us Dr. Samir Kubba as our esteemed speaker for the day. Sir is Director, Unit Head and Academic Coordinator of Clinical and Interventional Cardiology, Max Super Specialty Hospital, Ghaziabad. Sir is also Director of Mohan Heart Care Center, New Delhi. Sir has over 20 years of interventional and clinical cardiology experience and has numerous publications in national and international journals. Sir has been faculty and presenter at prestigious international and national cardiology conferences and has also been part of clinical trial as investigator. And Sir is also part of esteemed bodies as in CSI, LAI, API, ACC, and ESC. We are honored to have you here with us. I hand over the session to you, sir.
You will have to stop your screen sharing.
Yes, sir. Yes, sir. I'm doing it.
Thank you, Dr. Prajapati, and thank you, McLeod's, for this meeting. I hope my slides are visible.
Yes, sir.
Yeah, so today's meeting is on a very important topic, which is the role of ARNI in heart failure. We have been using ARNI for many years now. The advantage now we have is the cost has tremendously gone down. Our experience with this drug has been very, very positive, and it is a drug which has phenomenally changed the way we manage heart failure. And yesterday only, I had a patient whom I had advised a device therapy about a year back because she had left bundle branch block and LV function of 25%. She somehow was not keen for the device therapy. And day before yesterday, when we did her echo, her LV function is now about 50%. And she has been on the 4 pillars of therapy, and ARNI is one of them. So I believe this has transformed the way we treat. It's not that every patient has an improvement in the LV function. About 15 minutes back, I was seeing this patient of mine who has an LV of about 20-25%, no LVBB, normal coronaries. She had an episode of pre-syncope around 3-4 days back, and the ECG showed some NSVT. I've advised her an ICD therapy, but she again is not somehow keen. Her LV function has not improved despite being on ARNI. So there are many factors, but overall, I think our experience has been very positive, and many of our patients have improved dramatically, not only in the quality of life, but mortality benefit. And I'll be discussing things one by one today in this forum. So, as you all know, heart failure is a very, very big problem all across the world. India especially holds a more important place because not only we have more number of patients, but our patients are quite young, and they also have a high in-hospital mortality rate, which is to the tune of about 10 to 30% when compared to Western countries, wherein it is about 4 to 7%. And if you look at this heart failure report of 2020, it is a very startling figure that about 21 to 27% of heart failure deaths occur within 1 year of the diagnosis. If you look at the various stages of heart failure, stage A, according to the ACC, is a patient who doesn't have a heart failure as of now, but is at risk. He doesn't have any current or previous symptoms of heart failure, but he is at risk. And these are the patients who have hypertension, cardiovascular disease, diabetics, obese patients, patients who had exposure to cardiotoxic agents, family history of cardiomyopathy. And this is a huge chunk in our general population. So we must catch them early so that we are able to prevent their progression of disease. And even if it develops, we are able to prevent it. Then comes stage B, wherein patients do not have previous or current symptoms of heart failure, but have at least evidence of one of the three, and that is structural heart disease or evidence of increased filling pressures on the echocardiogram, and or clinically, and they have risk factors in association with either high natriuretic peptides or troponins in the absence of compelling diagnosis. Then comes stage C, which is asymptomatic heart failure, patients who have symptoms, signs of heart failure, and most of the times we catch these patients at this stage, although we should try and catch them early. And then is advanced stage of heart failure, wherein patients have marked symptoms which interfere with their daily life. They may have recurrent hospitalization despite attempts to optimize the guideline-directed medical therapy. Heart failure is a chronic disease which is interspersed with intermittent acute episode, and every episode is associated with not only a decline in overall quality of life, but also a decline in LV function, and probably may increase the mortality. So our aim must be to prevent these acute decompensations and also to prevent recurrent hospitalizations. We very well know for years that renin-angiotensin-aldosterone system and the sympathetic nerve system overactivation are the key sins in the heart failure with reduced ejection fraction. But there's a good molecule by the name of natriuretic peptides, which actually causes vasodilatation. Most of the years, what we have been doing is we are trying to combat the overactive pathways like sympathetic nerve system and the renin-angiotensin-aldosterone system, which initially are compensatory mechanisms in a failing heart, but eventually become detrimental. But now we have targeted neprilysin, which actually increases a good molecule by the name of natriuretic peptides. Beta blockers, ACE inhibitors, ARBs have tried to actually take care of overactive pathways which have now become detrimental to the failing heart. But neprilysin inhibition along with ARB, which is valsartan in this case, has tried to actually look at improvement in the heart failure by improving the level of good molecules. So if you look at overall management of heart failure with reduced ejection fraction in the last few years, it has actually changed, and these are the four basic pillars of therapy, which includes ACE inhibitors, ARNI, ARBs in case ACE inhibitors are not tolerated, beta blockers, SGLT2 inhibitors, and the mineralocorticoid receptor antagonists. Diuretics are the Ramban of acute decompensated heart failure. They do not improve the mortality, but they significantly improve the symptoms. So they are the sine qua non of almost all heart failure therapy, especially ADHF. But over the period of time, what needs to be done is try to reduce the dose of diuretics as much as possible and even stop them in patients who are not very symptomatic with breathlessness or do not have evidence of pulmonary edema. Because diuretics do not improve mortality, they only take care of symptoms. It's also important to manage comorbidities in the form of iron deficiency with the IV iron carboxymaltose. Sometimes patients may require a mitral clip or the MVR if they have significant MR, which is functional in nature. If the patient has associated atrial fibrillation, you may need to give anticoagulation, and digoxin at times may be considered. If the patient has a very fast ventricular rate and is not getting controlled with the standard drugs, or you have a contraindication to beta blockers, etc. Ivabradine has come to use if beta blockers are contraindicated or patient is not tolerating the beta blocker full dose and the heart rate remains more than 70, but the patient must be in sinus rhythm. A patient with AF, ivabradine is contraindicated as of now. If the patient has left bundle branch block and a QRS more than 130, the case which I was discussing, usually we offer a CRT. But yes, some patients may have an improvement in the LV function like the case I discussed, so you may avoid a CRT in such individuals. There is the role of isosorbide dinitrate and hydralazine in black population, and sometimes patients who have troublesome hyperkalemia and are not tolerating ACE, ARB, ARNI, or MRA, we use this drug, especially in patients with chronic kidney disease. And we also have a new drug which we have used to great effect in patients who have worsening heart failure, and that is vericiguat, which is increasing the level of nitric oxides as cGMP molecule. And despite this, if the patient has recurrent decompensation or features of advanced heart failure, LV assist devices or at times heart transplant may be required. If the patient is on optimal medical therapy, does not have left bundle branch block, and the LV function is less than 35% consistently, ICD may be considered in these patients. Now, why are we talking so much about heart failure despite this being a disease of so long? Now, the issue is despite the guidelines, despite the usage of beta blockers, ACE inhibitor, ARB, still residual risk persists. With ACE inhibitors, there was a 16% reduction in mortality versus placebo. With beta blockers, about 34%. With MRAs, about 30%. Now comes in sacubitril valsartan, because there's still a lot of scope to improve the overall mortality. And this is, I have already discussed in the previous slide, so I'll just skip it. Now, usually what this drug ARNI does is it improves the level of natriuretic peptides. It inhibits the neprilysin. And the usual starting dose of this drug is 50 milligram twice a day, and the maximum dose is 200 milligram twice a day. It is a combination of sacubitril and valsartan. 100 milligram dose contains 49 milligrams of sacubitril and 51 milligram of valsartan. And a 200 milligram contains 97 milligram of sacubitril and 103 milligram of valsartan. Now, if the patient is having a borderline blood pressure, if the patient is elderly, if the patient has severe renal impairment, has not been taking any ACE inhibitor ARB, and has moderate hepatic impairment, usually we start with a low dose. Sometimes the patient may be having a good body weight, hypertensive, so you can even start with the high dose. But usually we start with 50 milligram once a day or twice a day. At times you may need to start even with 25 milligrams and then up titrate it to a maximum dose of 200 milligram per day. In my clinical experience, most of the patients I have been able to achieve 100 to 150 milligram twice a day, and some of the patients only achieve 200 milligram twice a day. Now, if the patient has hypersensitivity to any of the components of this molecule, or has a history of angioedema related to prior ACE inhibitor or ARB therapy, then ARNI must not be used. And if the patient is on ACE inhibitor already, then you must stop the ACE inhibitor for 36 hours before switching the patient to an ARNI, because the patient may have otherwise angioedema, which can happen because of increase in the bradykinin levels. But if the patient is on an ARB, like telmisartan, valsartan previously, you can straight away switch over to ARNI. There is no need to wait for 36 hours washout period. As with every drug, there are certain side effects, which could be in the form of hypotension, hyperkalemia, cough, dizziness, and renal failure. But I think this is not very different from the ACE inhibitor or ARB. And yes, the amount of hypotension will be slightly more when compared to ACE inhibitor and ARB. But if carefully given and carefully monitored, this drug is a wonder drug. Yes, in pregnancy, lactation, and severe hepatic impairment, this is usually not recommended. So coming to the clinical studies, I think all of us know very well about the Paradigm heart failure trial. So this was a trial which was done in patients who had NIHA 2 to 4 heart failure with reduced ejection fraction. And these patients were randomized to 2 arms. Enalapril 10 milligram twice a day versus sacubitril valsartan 200 milligram twice a day. This was the final dose which we wanted to achieve in this trial, but obviously the drugs were started in a lower dose and gradually up titrated. And the primary composite endpoint was a composite of CV death and hospitalization due to heart failure. And there were many other secondary endpoints. And this is a trial which actually phenomenally changed the way of practice. And this was prematurely stopped because of the overwhelming benefit of sacubitril valsartan over enalapril. And so these patients showed that there was about a 20% reduction in the overall primary composite of cardiovascular death and hospitalization due to heart failure. and it started relatively early. You see the p-value here is less than 0.001. The hazard ratio of 80, 20% reduction in the overall composite of cardiovascular death and hospitalization due to heart failure. Benefit again seen very early. And the number needed to treat was just 21. So in any trial, if the number needed to treat is less, that means it speaks very highly about the efficacy of the drug. Study was halted early due to benefit of sacubitril valsartan, and a median follow-up was 27 months. So more patients died in the enalapril group, so it was not worthwhile to continue this trial. So this trial phenomenally changed the way we practice. And if you look at the components of the primary endpoint, individually, if you analyze cardiovascular death, it was reduced by 20%. If you look at hospitalization due to heart failure, it was again reduced by about 20%. So all p-values on the right side were significantly better in the sacubitril valsartan group when compared to enalapril. And it was irrespective of the ejection fraction. It was irrespective of the baseline presence or absence of atrial fibrillation, irrespective of the baseline NT-proBNP levels, irrespective of hypertension, prior use of ACE inhibitor, aldosterone antagonist, and prior hospitalization for heart failure. And mind you, this trial actually used very good guideline-directed medical therapy. More than 90% of the patients were on beta blockers, more than 60%, about 58% were on MRAs. So on top of this, there was a 20% reduction. You can see how beneficial this drug was. So it was concluded that ARNI reduces mortality about 16% over and above the ACE inhibitors. And this was clearly shown in the Paradigm heart failure trial. Then came in the Pioneer heart failure study. We tried to look at expansion of this drug in the indication of a patient who has been recently admitted with an acute decompensated heart failure. So, you know, whenever a patient has a chronic heart failure, there is always a period in which he gets acute decompensation, either because of an infection, because of an arrhythmia, because of associated CAD, pregnancy, etc. So many things can cause acute decompensation of the stable heart failure. Now, what they did was in this trial that they stabilized the patient first, and once they were stabilized, which means they should have achieved 4 criteria for stabilization. The number one, systolic blood pressure of more than 100 in the last 6 hours, no symptomatic reduction in the blood pressure, no increase in the IV diuretics in past 6 hours, no IV vasodilators in the past 6 hours, and no IV inotropes in the past 24 hours. So when the patients were stable enough, they were randomized either to enalapril or to sacubitril valsartan, and they looked at the fall in the NT-proBNP levels depending upon the various regimens. The initial regimen was 50 milligram twice a day of sacubitril valsartan, or enalapril 2.5 milligram twice a day. The level 2, when the blood pressure improved, increased the dose to twice. And then level 3, when the blood pressure further improved, it was given the maximum tolerated dose of 200 milligram twice a day, which was the trial dose. And what they found was there was a significant reduction in the NT-proBNP levels when compared to enalapril. And it was not only significant, it was very, very early. Within 1 week, the response was seen. And if you look at 8 weeks, there was a 30% relative risk reduction in the levels of NT-proBNP when compared to with sacubitril valsartan when compared to enalapril. And when there was an open label extension of this trial up to 12 weeks, again, there was a 37% reduction. And if you explore this analysis, that how these patients will fare over a period of time, this is an exploratory analysis. It is not an actual analysis, but if you explore it, that the way NT-proBNP level reduced and the way the patients showed improvement, there would be a reduced risk of serious composite endpoints of death, hospitalization due to heart failure, and the need for a transplant or the LV assist device. And this was irrespective of the fact that the patient had de novo heart failure or a worsening heart failure, or the patient was ACE inhibitor, ARB naive, or no. So in all these scenarios, the improvement in the NT-proBNP was phenomenally higher when compared to the ACE inhibitor, ARB in the sacubitril valsartan group. So what this trial concluded was that in high-risk subgroup, who are patients admitted with acute decompensated heart failure, treatment with sacubitril valsartan after initial stabilization conferred a consistent reduction in CV death or rehospitalization for heart failure and was also well tolerated. One of the basic issues what happens with ARNI is that if you start it in a borderline hemodynamics or if the patient has not stabilized enough, then the patient can have further hypotension, which can further worsen the patient. So you have to understand at what point you need to start this drug. So initially the paradigm excluded these patients, but Pioneer included these patients of recent ADHF and also showed benefit. Now, reduced ejection fraction, we have had enough evidence. There are many more other trials also. But what about reserved ejection fraction? And this is something which is an epidemic nowadays. Patients have normal LV function, but they have symptoms of breathlessness and heart failure. The rising pandemic of hypertension, diabetes, obesity is increasing the patient with HFpEF. So this trial actually, Paragon heart failure trial looked at about 4,800 patients who were in NIHA 224 and had an ejection fraction of more than 45%. The paradigm had less than 35%, but this was more than 45%. And again, sacubitril valsartan was compared to valsartan, and number of total hospitalizations for heart failure and CV death, the same primary endpoint was used in this trial, but it narrowly missed the primary endpoint. So you look at the p-value here, it was 0.06. So it did not achieve the magical figure of 0.05, but although the p-value was 0.06 and trial was said to be a negative trial as far as the primary endpoint is concerned, but if you look at the subgroup analysis, especially in the patients who had LV function between 45 to 57%, females and patients, these patients actually benefited and they did much, much better with sacubitril valsartan when compared to valsartan. Yes, patients with LV function of more than 60%, probably the benefit was less. But if the patient was a female and if the patient had LV of 45 to 57%, these patients definitely did benefit. So what is the sweet spot in heart failure? I think heart failure is a disease in which ejection fraction keeps on swaying up and down at times, and it is also observer dependent. But I believe that if you have an LV function around 55% or even up to 60% and you don't have other choices, you can still use ARNI. For HFrEF, definitely, there's no doubt that ARNI must be used. Now, what do the guidelines say? So depending upon the actually having a phenomenal benefit seen with this drug, the ESC 2021 heart failure guidelines say that all patients must receive ACE inhibitor or ARNI, beta blocker, MRA, and SGLT2 inhibitors to reduce mortality in patients who have heart failure with reduced ejection fraction. And this is a common slide you have seen in multiple CMEs. And it just reiterates what I have previously mentioned about the need for these 4 pillars and then followed by need for a device therapy in the form of ICD or CRT, depending upon presence or absence of LVVB and the QRS duration. And if you look at the further of the guidelines, the ESC guidelines say that sacubitril valsartan is recommended as a replacement for an ACE inhibitor in patients with HFrEF to reduce the risk of heart failure, hospitalization, and death. The class of evidence is 1, the level is B. The level is not A because you have just one trial paradigm. If you have more than one trial, you achieve a level of A, but there was no other trial which was required because of the phenomenal benefit of more than 20% and reduction in mortality over enalapril. So no further trial will be conducted in that population. So although this is 1B recommendation, for us, for all practical purposes, it is a 1A recommendation. And sacubitril valsartan must be considered in patients with mid-range ejection fraction between 41 to 49% to reduce the risk of heart failure, hospitalization, and death. And this is class 2B with the level of recommendation C. Now, these patients can be either stable patients of OPD in which you can start, or even in IPD patients, once they are stabilized, their congestion is relieved and their euvolemia is restored, then you can start even in IPD patients. Now, how to use? Check the renal function and electrolytes in these patients. Start with a low dose. You may consider reducing the starting dose to 50 milligram twice a day if the blood pressure is between 100 to 110. Patient is ACE inhibitor or ARB naive, and the eGFR is between 30 to 60. And try to achieve the highest possible tolerated dose for these patients. Double the dose at not less than 2-week intervals in community and monitor the tolerability. So these are very, very important points. Sometimes the patient may tolerate the drug very well. Sometimes the patient may not tolerate. Sometimes the patient may be on associated nitrates, which may be causing hypotension, and nitrates are not required because the patient doesn't have angina. And still many patients will have nitrate therapy on board. Sometimes the patient may be on alpha blockers for their prazosin or for Urimax, etc., for their BHP. That can further cause hypotension. So you can actually see how much that is required. Look at other drugs which can cause hypotension and try to reduce their dose, because benefit of mortality with this drug is extremely high. We have to check for the urea, creatinine, potassium, as we do for all ACE inhibitors, ARB. We must strongly consider reducing the diuretic dose wherever appropriate, because diuretics provide definitely symptomatic benefit, but there is no mortality benefit, and at times they can cause troublesome hyponatremia, hypokalemia, and dyslipidemia. So try to reduce the dose of diuretics as early as possible. Monitor the blood chemistry 4 monthly thereafter. Very rarely it is necessary to stop an ARNI. You may actually reduce the dose and then re-escalate it depending upon the clinical scenario. But another point we must remember is that when you withdraw treatment, the TREAD heart failure trial for other drugs and also for ARNI, we have seen there's a clinical deterioration which is likely after when you withdraw these drugs. So withdrawal of these drugs should not be attempted in most cases unless and until you are extremely, extremely sure that the heart failure was because of a transient or a reversible cause. Now, what do the ACC, AHA, and HFSA guidelines of 2022 say? So they say that in patients with HFrEF and NIHA class 2 to 3 symptoms, use of ARNI is recommended to reduce mortality and morbidity. Level of evidence is A, class of recommendation is 1. So it's a 1A indication. In patients with chronic symptomatic HFrEF who tolerate ACE inhibitor or ARB, replacement of ARNI is strongly considered to further reduce mortality and morbidity. And again, the recommendation is 1B. In patients with chronic symptomatic heart failure and reduced ejection fraction, treatment with ARNI instead of ACE inhibitors provide high economic value, because even if you are able to prevent one hospitalization, you can do a lot of benefit on the pocket, and also the overall mortality is improved because every hospitalization is usually associated with a further decline in the LV function and also a transient and probably a translation into increase in the mortality over a period of time. ARNI should not be administered concomitantly with an ACE inhibitor or within 36 hours of the last dose of ACE inhibitors. It's a class 3 recommendation, and should not be administered to any patient with any history of angioedema. So these are some of the conditions you have to be extremely, extremely cautious before starting an ARNI. Coming to mid-range ejection fraction, which is between 41 to 49%. Diuretics are class 1 indication. SGLT2 inhibitors are class 2A recommendation. ACE inhibitor, ARB, and ARNI are class 2B recommendations. The MRAs are also class 2B recommendation, and evidence-based beta blockers again are class 2B recommendation. Among patients with current or previous symptomatic heart failure with mid-range ejection fraction or mildly reduced ejection fraction, use of evidence-based beta blockers for HFrEF, ARNI, ACE inhibitors, ARB, or MRA may be considered to reduce the risk of heart failure hospitalization and cardiovascular mortality, particularly among the patients when the LV function is on the lower end of the spectrum. So if you have an LV function which goes beyond 60%, maybe the benefit is not that great, but less than 60%, or I would say less than 57%, probably the benefit is still there. And then if you have heart failure with preserved ejection fraction, again, the recommendations are almost similar. And in selected patients with HFpEF, ARNI actually should be considered to decrease hospitalization, again, with the patient who have LV ejection fraction on lower end of the spectrum. One practical issue which I have seen and I have used effectively this drug is hypertensive patients who have preserved ejection fraction but have recurrent breathlessness. and they get admitted often, you can control these patients much better with an ARNI because it is a much better antihypertensive when compared to ARB and ACE inhibitors. And even in patients with resistant hypertension, I have found the role of ARNI very beneficial, although it is not a guideline recommendation. But this drug actually takes very well a reduction in the blood pressure, and you can reduce certain other antihypertensive which the patient may not be tolerating. So how do you actually practically go about chronic stable heart failure and reduced ejection fraction? If the patient is stable, start with an ARNI and SGLT2 inhibitor, may also use a beta blocker, continue the beta blocker, and over 2 to 4 weeks, up titrate the therapy and add other two drugs. In acute heart failure, probably at the time of admission, you have to discontinue the ACE inhibitor ARB, and then beta blockers can be initiated. And once the patient is in the hospital, you can stabilize this patient and start an ARNI and SGLT2 inhibitor in the hospital, and then escalate the dosage of these drugs as an MRA. So finally, in all sort of heart failure situations, by 2 to 4 weeks, you must have all these 4 drugs on board, the 4 pillars of therapy. You can decide on your own, depending upon your clinical judgment, depending upon specific indications, which drug to start first. So suppose the patient has troublesome hyperkalemia, maybe SGLT2 inhibitors and beta blockers are the drugs to be initiated. Suppose the patient is hypertensive, maybe ARNI is the first drug to be initiated. So suppose the patient has severe COPD, maybe you cannot use beta blockers, so you have to use ARNI and other drugs, or even ivermectin. So these are some of the aspects which we must understand and do the jugglery of medical therapy accordingly. Which drug to use first can be a matter of choice depending upon the clinical scenario, associated comorbidities, and associated risk factors. But we must try to achieve all these 4 foundational therapies over a period of time. And rapid up titration is much, much more beneficial than a slow up titration. So to conclude, sacubitril valsartan has actually satiated the important need gap in heart failure management. It reduces cardiovascular death, hospitalization due to heart failure, all-cause mortality, over and above ACE inhibitors, especially in patients who have reduced ejection fraction. There's also an improvement in quality of life. The KCCQ score also improves in this patient. I did not talk much about it, but quality of life also has shown a significant improvement, and that is also very, very important in heart failure. Heart failure at times, recurrent heart failure, recurrent hospitalization can markedly reduce the quality of life, not only for the patient, but also for his family. It can increase the risk of depression. It will increase the cost. It will increase the mortality. So quality of life also is very, very important. It's a class 1 recommendation in multiple guidelines for HFrEF. It has a selected role in HFpEF patients, but again, especially if you have multiple comorbidities, high blood pressure, and lower end of the EF spectrum, probably the benefit is there. Early initiation and up titration is recommended for maximal benefit. Thank you very much, and I'll be happy to take questions.
Thank you, sir. Wonderfully explained. And you also shared your practical experiences. Surely our audience would have benefited from it. So we have few questions. You have answered these questions in your session, but it would be great if you reiterate on it again. So the first question is, what clinical factors do you consider after stabilization of ADHF to initiate ARNI?
So that's a very good and practical question. So see, first and foremost, we must understand that when we discharge a patient, it is a very, very important time. It's the vulnerable phase. And at times we have worked very hard on the patient for 3 days, 4 days, 5 days. And when they discharge, somebody is being made by our associate or our coordinator. At times we may not give that much of an importance to discharging. So initiating the drugs before discharge becomes very, very important, because there are high chances that the patient will continue this drug, and you will also not forget to continue this drug and fill his prescription when he comes to OPD. Sometimes the patient may be lost to follow-up also. So once your patient is stable in the hospital, that means his diuretic requirement has reduced. He is not hypotensive for last 24 hours. There is no inotropic therapy on board, and he is euvolemic. At this point of time, you must initiate ARNI or an SGLT2 inhibitor or whatever drug, probably in a low dose, up titrate it in hospital for a day or so, or even if just observe the same dose, maybe you can start even with 25 milligram and then see how the patient tolerates and then discharge the patient. Try to look at all the fourth fillers if you have been able to initiate. And I think the question needs to be asked is, instead of have I initiated, the question you need to ask yourself is, what is the reason I have not initiated a beta blocker or a SGLT2 inhibitor or an ARNI or an MRA? What is the reason I have not initiated? And note that, maybe make a heart failure sort of a chart in your patient's file. The nurse can be trained, your associates can be trained, and the reason for not starting therapy must be mentioned, so that when the patient, and a copy of this is given to the patient, so that the patient, when he follows in the OPD, he brings that, and then you can reinitiate, you can initiate the other drugs or even up titrate these drugs. So idea is to start all these drugs, but practically at times you may not be able to start all the 4 drugs together. So usually you may be able to start maybe a beta blocker and SGLT inhibitor, or maybe an ARNI and a beta blocker, maybe ARNI and SGLT2 inhibitor, maybe MRA and beta blocker. So most of the times, if the patient is fairly hemodynamically stable, ARNI must and should be initiated. With SGLT2 inhibitors, good drugs, but what I have seen, many of these admitted patients with ADHF have been on Foley's catheter. And although a lot of precautions are taken by nurses and all of us, still infections do happen, especially in elderly patients and especially in ladies. And I have burnt my fingers in few scenarios wherein the patients have been started on SGLT2 inhibitors in the hospital. They go home and come back within 3 to 4 days with a UTI, or they come back with some fever, or they come back with some dyslipidemia. So that is not a problem with ARNI. So that is one advantage. So the clinical scenarios may be different, clinical scenarios may be wide, but we must try to achieve or at least start these drugs before discharge. And if not all drugs, at least when they come back to us for the first follow-up after 7 days or so, maybe start the 3rd drug and then call them early after 1 week, start the 4th drug and then gradually up titrate them.
So the next question is, what is the maximum dose of ARNI that most patients in Indian scenario tolerate?
Very good question. Very good question. So in my experience, it is 100 milligram twice a day or 150 milligram twice a day in most scenarios. 200 milligram twice a day, I would say less than 10%. Maybe 150 milligram twice a day, I would say about 30%. Maybe 100 milligram twice a day, about 40%. And about 10 to 20%, 50 milligram twice a day. Sometimes you may even have to continue just with 25 milligram. The patient which I was seeing today, her blood pressure is around 100 by 60. She has episodes of giddiness. So I have not been able to escalate beyond 50 milligram once a day, because I have been giving her beta blockers, I've been giving her MRAs, I've been giving her SGLT2 inhibitors. So her blood pressure remains around 106, 104. So she's on 50 milligram.
So, and even Asian patients, they are not able to tolerate the maximum dose, unlike the Caucasian, we see normally.
Yeah, Dr. Prajapati, that is another concern, but some of the patients may tolerate 200 milligram twice a day. Their blood pressure is good. They are young. They have high body weight, and their LV function is around 35-40%. And they wonderfully tolerate 200 milligram twice a day also. So you have to see and individualize your patient, and wherever you are able to. And if these patients are hypertensive also, then again, the blood pressure reducing effects of ARNI are much, much better. So I have patients who are tolerating 200 milligram twice a day for quite some time, for years now.
So the last question is, ARNI and MRA both can cause hyperkalemia as side effect. So what titration strategies you recommend to minimize such side effect?
So very good and practical question. See, if you even forget about ARNI, before ARNI came into the picture, MRAs still were class 1 drugs, and ACE inhibitors, ARB were class 1 drugs. Beta blockers, obviously. SGLT2 inhibitors and ARNI are late entrants. So the same aspects or the same nuances hold true even after the introduction of ARNI, because ACE inhibitor ARB also, when you combine with MRA, hyperkalemia is high. But let me tell you one very important and interesting finding. When you combine an ARNI with MRA, the risk of hyperkalemia is lower than combining an ACE inhibitor with an MRA. So ARNI, probably because of the neprilysin inhibition component sacubitril, the risk of hyperkalemia is low. So that is an advantage of ARNI. Having said that, it's also important not to blame MRA or ARNI as a villain in hyperkalemia. Many times the patients may be having a potassium-rich diet, and that needs to be seen, and you need to actually delve into their history. And if they are on a potassium-rich diet, that needs to be taken care of. And a practical way is to keep a chart on your clinician table and maybe ask, are you taking these things like pumpkins, bananas, juices, certain curds which have preservatives. So, I mean, these are certain sort of things which patients might be taking. And sometimes the patient may be taking over-the-counter drug like NSAIDs. So that can also increase the risk of hyperkalemia. So concomitant drugs and diet, that needs to be taken care of. And if you have to withdraw a drug, usually we withdraw the MRA. If the patient can have a regular follow-up with you, then probably you can give them the benefit of this combination therapy. If the patient gets lost to follow-up or is not a very good person who is coming to you for follow-up, then be very worried, because we have seen patients having severe hyperkalemia and having a cardiac arrest or coming with heart block. So that also needs to be taken care of. So potassium monitoring becomes very, very important. If your patient is regularly following up with you and you are able to take care of these things, then they can get the benefit of a combination therapy.
Thank you so much, sir, for the detailed explanation. So just one last thing I wanted to know. 25 mg BD ARNI is also given, sir. And with that dose, does the benefit of sacubitril is seen? Because in order to see the benefit of sacubitril, we have to increase the dose. That is what the text says. So how do you look at it?
Any dose is beneficial. So there is data from sub-analysis of the paradigm, which shows that even if you are able to use 25 milligram once a day also, still the benefit is there. Now, there are a category of patients who will just not tolerate a dose beyond 25 milligram twice a day. And these are the patients who per se are also high-risk patients. Their overall mortality otherwise is also high. So any dose is better than no dose. Yes, if you are able to increase the dose, the benefit is higher. But even a low dose has benefit. It may not be as great as the maximum tolerated or guideline directed dosage, or the maximum not tolerated, the maximum advised trial dosage. But still 25 milligram BD can also be better, and there is data to prove it.
Thank you, sir. So your final thoughts on the topic today for the audience.
I think heart failure management is both an art and a science. We really need to know our patient very, very well. We need to know his family very, very well. We need to counsel this patient very well. And the importance of drug therapy in heart failure cannot be overemphasized. At times, the patients are stable, they come to you and you increase the dose of drugs, and their common question is, if I'm fine, why are you increasing the dose of my drugs? I'm absolutely fine. So telling them that we have to put you on the maximum tolerated dose or the guideline directed dose or the trial dose to give you maximum benefit, educating them becomes very, very important. And discontinuation is associated with a rebound and recurrence. These 4 pillars must be instituted. The role of IV iron is also very, very important, and one must look for iron deficiency in heart failure. The role of vaccination is also extremely important. We generally do not discuss vaccination in meetings, but it is extremely important, especially for reduced ejection fraction patients with heart failure. Our ICUs and our ICUs and CCUs get filled up during the winter seasons, and many of us do not advise proper vaccination to these patients. I think physicians may still advise, but cardiologists many times fail to do that or forget that. So vaccination is also extremely important. Assessment of iron deficiency is very, very important. You have to give these therapies in the guideline-directed medical dosages. You have to understand the family. You have to have a heart failure clinic, whatever way you are able to. At times, you may not have the luxury of a counselor or your specialist. There are now online programs also, but you can actually train your clinic boys who can give basic sort of education to these patients. It's also very, very important that these patients are regularly followed up and they are made actually responsible partners in their own treatment. It's a long journey. It is something like a marathon. It's not a sprint. The whole family is affected. And with cancers, people are more sensitive, but with heart failure, somehow or the other, the sensitivity is less because it doesn't give that kind of a malignant potential. But I did not discuss in the slides, but if you look at mortality, certain forms of cancer actually do well when compared to heart failure. So CA breast or CA prostate, these patients may live longer and their mortality rates may be lower as compared to patients who have heart failure with reduced ejection fraction. So it's very, very important that we understand these things and treat our patients with our heart and soul and take care of this problem together.
So that was wonderful session, and it was pleasure having you here and listening to you. So with this, we come to an end. We thank you for taking out your time from the busy schedule. We also thank our audience for their patient listening and our technology partner for smooth streaming of the session. Thank you so much, sir. It was wonderful listening to you.
Thank you.
So, ma'am, with your permission, now can I end this meeting?
Yes.
Okay, so thank you everyone for joining today's session. So now from here, we are closing this session. Thank you.